Hi, I'm Dr. Torino and I'm a faculty here at EVMS in the ultrasound department. And today we're going to talk about a focused liver assessment exam. And for our focused liver assessment, we're going to try and meet the following objectives. First of all, we're going to consider this part of a point of care ultrasound exam. We're going to talk about machine setup. We're going to talk about your patient setup and the acoustic windows available. We're going to go through the acquisition of your images, go over some pitfalls and pearls, and then I'm going to introduce you to the scanning direction cards for this segment, which are available for you on Blackboard. The purpose of a focused assessment of the liver is to evaluate liver parenchyma to determine if there is a potential mass present, to determine the size. Specifically, we're going to focus on the length of the liver and potential hepatomegaly. We will be able to determine the presence of free fluid in the right upper quadrant, and we should be able to assess the gallbladder in most patients to see if there are gallstones present. We are going to set up the machine with our patient data. And that will have been given to you beforehand in Blackboard. But we're going to start with the preset of an abdomen with a curvy linear probe. Now, a phased array is absolutely acceptable, but typically we'd be using a curved linear. While you're setting up your machine, you're going to leave everything pretty much the way it is, and then once you begin scanning, you'll make adjustments to your depth, your gain, and your focal zone. And because we're looking at the liver, a very large organ, you'll have to make almost continual changes to those controls. So now I'd like to go to the machine and enter patient data. So we're going to start here with the patient button. And for this exam, the last name is going to be liver. And because this was set up as part of gastrointestinal and metabolism, GI and M, we're going to label this as MD 105 for the first name. And then I'm going to come down with my trackball to OK, and I'm going to hit set. I'm going to then come to my exam button and make sure that I'm still on the abdomen preset. And now our machine is ready to go. So when we start talking about setting particularly our gain, we start with all the paddles lined up along the central axis, right here, straight down the center, and then once we are scanning, we can decide what adjustments we'll need to make. So as I go back to my PowerPoint, I want to talk to you about patient positioning and our probe orientation. So the probe marker convention will be the standard that we have been using, and we're going to use the probe marker, the dot on the probe facing patient head for sagittal images, and then the probe marker will rotate counterclockwise so that it is facing towards patient's right in a transverse scan. The probe movements that we're going to use are likewise going to be our standard motions. When we talk about the probe marker represents the toe portion of our probe. So we can heel or toe and rock our probe to look either more superiorly or more inferiorly in this sagittal plane. We can also sweep or fan, and we can pivot or rotate our image. The patient positions that are optimum for liver, certainly supine is an option, but we may find that we have to roll our patient LPO or even LLD to adequately move the liver out from under the rib cage. So primarily, our acoustic window is going to be a subcostal margin, and you're going to scan along the patient's costal margin as you move from left liver into right liver. What you have to remember is that anything you look at really between diaphragm and belly button means you have to ask your patient to take in a big breath and hold it. And that deep held inspiration will help drop the diaphragm and push the liver closer to your probe. Now, sometimes subcostal scanning is not suitable. Sometimes it has to do with the lie of the liver, body habitus, and in those cases you may need to scan intercostally. Be aware that in those cases you're going to have much more shadowing from those rib interfaces. And then one more technique that can at times be helpful, and it sounds a bit silly, but if a held inspiration is not effective, then you can ask your patient to pooch out their tummy, and as they push their tummy out, what it does is it flattens all of the stomach and duodenum at midline to push it away from your acoustic window. So that may be helpful. Our image acquisition is going to begin, we're going to begin on the left lobe of the liver and then move into the right lobe. Again, you're going to continually adjust your depth, focal zone gain, and orientation. And an important point to make here is in your scanning cards. It makes it seem like you get 4 images and you're done. Please remember that if you look at something with ultrasound, you must look at that anatomy in 2 scan planes. So we must look at the left and the right lobes of the liver both sagittally and transversely. Okay. All right, now I'm going to put some gel on our patient. Sorry. So when I begin and just put the transducer on the abdomen, I am very high on the abdomen, just subxiphoid. And will you please take in a breath and hold it? And you can see just that breath in really increases the view of liver anatomy we can see. So when I'm here in midline, at midline of the body, I'm looking at the left lobe. And anatomically, you have this thin hyperechoic echo, and that represents the ligament venosum. And deep to that ligament venosum, we see the patient's caudate lobe. If I breathe, please. Sorry. Big breath in, please. One of the things I want you to notice is in the left lobe, the liver is fairly superficial. So I can decrease my depth. I'll come back 1. My focal zone is set appropriately for this left lobe. I do want to show you this hyperechoic tissue that sits deep to the liver. Let your breath out, please. Is pancreas. So there's a lot of anatomy right here. Breath in, please. As I start to move towards the right lobe of the liver, I encounter the main portal vein, and there you might notice a portal triad. I also see some left portal vein right here. You can tell what kind of vessel you're looking at because portal veins have very bright, breathe, hyperechoic walls. And big breath in, please. And hepatic veins do not. So here's a hepatic vein with a hypoechoic walled vessel. And here are little pieces of portal vein throughout the image with bright walls. Here, as we move into the right lobe, also you'll see the gallbladder. So this hollow pouch filled with bile. Breathe, please. And then also at about this level, breath in, please. You'll notice that we're starting to encounter some dropout deeper in the image, and so I'm going to need to make some adjustments. I need more depth, for one thing, and I need to drop my focal zone, 1. And now I can look at the rest of the right lobe. Breathe really nicely and breath in. And here you can see some hepatic veins and some portal veins very clearly. And I want to look, when I look at this liver, I want to look all the way up into the dome of the liver so that I can make sure there's no masses. Breathe, please. Now finally, still in my sagittal scan plane, breath in, please. I'm going to effectively get a Morrison's pouch shot. And I'm going to try and get in as much of the length of the liver, breathe, as possible. And I'm going to measure the length of the liver, and I'm going to set my first caliber as inferiorly as possible, and I'm going to follow the kidney-liver interface, and I'm going to set my second caliber at the inside border of the diaphragm. And we would expect a normal liver to have a length of less than 17 centimeters, and our patient has a liver with a length of 16 centimeters, so that's quite normal. Another thing I'd like you to look at on this image is the right posterior lobe of the liver. And if the right posterior lobe of the liver extends inferiorly beyond the lower pole of the right kidney, the patient has what is called a Rydell's lobe, a normal variant. This normal variant is very common in women, much more commonly seen in women than in men. And you have to be careful that you're trying to separate this out from hepatomegaly. So one of the first things I look at is my subcutaneous layer. And here I see this a very thin patient, and so this really represents probably a very long and thin liver. Now from this required image, I'm going to, before I go to transverse, I want to talk about one more distinction that you have to make sonographically, and that is the difference between the aorta and the IVC. Because you have to pay attention to your vasculature and what vessel you're looking at. Taking a big breath, please. So the aorta is on the left side of the body. IVC is on the right. The aorta has anterior branches coming off of it. The IVC really does not. There's nothing posterior to an aorta, but there is a nice right renal artery posterior to the IVC. Additionally, the aorta sits posterior to the diaphragm, quite deep in the body proximally, but the IVC pierces the diaphragm, and you can see a little bit of diaphragm always deep to the IVC. So always pay attention to your landmarks and your vasculature. Now I am going to rotate my probe counterclockwise 90 degrees and then breathe, and I am at my left lobe, and so now I'm going to make sure I look all the way to the tip of the liver, and again look at how long the liver is in this female patient. Just this real nice long slender liver. And so here is left, all of left lobe. Breathe please, and breath in again when you're able. And here we have ligament venosum and caudate lobe again, and here you can see that caudate lobe sitting anterior and a little bit to the left of the IVC. So from here now I'm going to angle slightly. Breathe. First I'm going to let my patient breathe like a nice sonographer. Breath in again when you can. And I'm going to angle quite superiorly and quite to the right, and I'm seeing hepatic veins as they enter into the IVC. And I can confirm that there's flow and that that flow is going in the correct location just by putting on my color Doppler, where blue flow represents flow going away from the transducer, in this case towards the IVC. Breathe. Breath in again. Now as I continue to scan again along the costal margin, the first thing I get to is a big hyperechoic walled portal vein. This is the right portal vein, and this will be a great landmark for you. But notice that my liver is getting cut off. So again, I need to adjust my depth for the right lobe. Breathe. Thank you. And now I'm going to continue to slide along the costal margin from right portal vein. The next thing I'm going to get to is going to be gallbladder. Here's right kidney. Still this long right lobe of the liver. And then I'm going to look up in the dome subphrenically to make sure I've evaluated for any potential masses or fluid. Breathe. Thank you. Now I'd like to go back to my notes and remind you of some of the common artifacts we may encounter. You may see mirror artifact, and mirror artifact often is seen superior to the diaphragm. You may see some reverberation, some posterior enhancement, some posterior shadowing, dirty shadowing, which you would see near bowel, and edge artifact, which you might see near the gallbladder. We've talked about the differences in these vessels, so I'm going to skip over this but remind you that these anatomic references are going to be very important landmark vasculature structures for you: the portal veins and the hepatic veins in the liver, and then our great vessels, the aorta and the IVC. We also then come to the required image of measuring the liver itself from inferior to superior, a bit along the kidney-liver interface, and again a reminder that that length should be less than 17 centimeters. Again, a common variant, a Rydell's lobe, an inferior extension of segment 6. And it is considered a Rydell's lobe if it travels inferior beyond the lower pole of the right kidney. An SPI pearl. Because physics is my thing, this is the biggest SPI pearl yet. And so I want to remind you that our machine is limited by time. And everything that your machine does requires that the sound go into the body and return to the machine. That takes about 13 microseconds for every centimeter. So what that means to you is if you have to look deeper in the body, then your machine will require more time to get that task accomplished. And that means side tasks that you might be asking of your machine, like a dual image or color, any other control that we want to add in, will slow our frame rate or refresh rate down. And in the end, everything in our machine is limited by time, and everything can be tied back to a mathematical formula. Your scanning cards are going to be located on Blackboard. I do want to just take this quick minute to show you a brief introduction to them, because the way they are set up, they remind you that you are looking at a dynamic scan of the entire liver, and that you are choosing focused images to selectively document that process. And so you are looking at the left liver, which shows in this first image the IVC and the caudate lobe and the ligament venosum. And then your second image would be looking at a multi-segmented lobe of the liver using the hepatic veins to divide the left lateral lobe from the left medial lobe, and then the left lobe more largely from the right lobe, and we come into the right anterior, and then finally that right posterior lobe. Remember, to get this image, you have to oblique superiorly and to the right. Then finally, you're going to continue moving inferiorly and to the right through the liver. You're going to look at the right lobe in several locations, including this major landmark of the right portal vein, and then finally a document of the length of your liver and that measurement. Now notice that these cards each have a single scan plane, and you must remember that you have to look at everything in both scan planes. And I want to just remind you that liver size really is most accurate when it is calculated as a volume, but sonographically we rely most heavily on the length of the liver to assess normalcy. And that is the end of this presentation. Thank you.